So what are we going to do? We're going to take history. So on the history, what do we want? We want to know how long has the mess been there? And the mess, is it painful? Does it come and go? Or is it cyclical? Those are the things that you want, and you want to know which location is it when you found it. So it becomes easy for you to do follow-ups and also to do an FNA. If you choose to do an FNA, you know where the lump is. You can even attempt to express whatever that might be coming out of the nipple, be it a pus or a discharge or milk, whatever. You want to try and see what's happening then. That's your physical examination. Obviously, you will do your physical examination now, your systemic, and check, especially if you have a patient that already they've got obvious stage 4 sort of, they're already stage 4 breast cancer. So you want to check if there are any ultrasound they can quickly check for you. Yeah, so this one can help you with deciding if the mess that you are feeling, whether it's cystic or it's solid. A solid mess has got higher chances of being malignant compared to a cystic mess. If it's cystic with fluid, you've got a chance to aspirate the fluid and send for cytology. And also pick up other messes that maybe you couldn't pick up with the ultrasound. But this is the number one. The mammogram is very good picking up malignant lesions. It's a gold standard. But now, once you find that, okay, this patient actually has a solid mess, because this is what we want to talk about. Because I said we want to talk about malignancy here. We'll talk about the conditions, benign conditions of the breast, but today I'm biopsying. When you take that tissue to the pathologist, you are gonna get a report that will tell you 5 things. When that report comes, that report will tell you about it will tell you, number 1, whether the mess that you did a biopsy on, whether it's benign or malignant. If it's malignant, it's going to tell you if it's lobular or ductal. Lobular, it can be lobular carcinoma in situ, or it can be invasive. Even the same this side, ductal carcinoma in situ or invasive. So the word in situ means that the cancer is not invasive, so it doesn't go past or go through the basement membrane, but it might become invasive, so they are still managed. So that means it's ER positive, or it can have receptors for progesterone, or it can have receptors for what is called HER2. So a cancer that has receptors for estrogen, it means that cancer is dependent on estrogen to grow. Same applies of cancers. If you deny them estrogen, they won't grow. If you deny them progesterone, they won't grow. But if they are not dependent on that, even if you deny them, they will still grow, because they are not using your progesterone or your estrogen or your HER2 to grow. Those cancers, they are cancers that do not have any of these. Those cancers are called triple negative cancers. They are very aggressive, and it's very hard to manage, because you can't use your tamoxifen or your trastuzumab and all those things. So